All right, let's jump right in. Today, we're doing a super fast breakdown of acute stroke management, looking at it completely through a pharmacist's eyes. We're going to move quick, focusing on those key moments where your knowledge can literally change a patient's life. So let's get to it. You've heard it a million times, but it is the absolute truth that drives everything we're about to talk about. Every single second that ticks by, millions of brain cells are dying. This idea, this race against the clock, is behind every decision, every medication, every single thing we do. And that race starts with just recognizing there's a problem. FAST is more than just a public service announcement. For us in the hospital, it's the first bit of clinical data we get. A drooping face, a weak arm, jumbled speech, those are the alarms. And T for time, that means it's go time for us. So a code stroke is called. We're officially in a brain emergency. But here's the thing, it's not just one single problem. This emergency splits off into two very different paths, and each one requires a completely opposite treatment plan. And here is that split. The vast majority of the time, about 85%, what we're looking at is an ischemic stroke. That means there's a clot blocking blood flow to the brain. The other 15% of the time, it's a hemorrhagic stroke, a bleed. Now, even though it's less common, getting this diagnosis wrong is, well, it's catastrophic. This one piece of information changes everything. Which brings us to the most critical first step in this whole process. Before we even think about pulling a single drug, we have to know the answer to one question. Is it a clot or is it a bleed? The entire game plan depends on getting this right. So what is it? What's the one test that's going to give us our answer? The one thing that sets the course for everything that follows? There it is, an urgent non-contrast CT of the head. It's fast, every hospital has one, and it's the gold standard. For a really simple reason. It shows us blood. If there's a bleed in the brain, it lights up on the scan. And that tells us exactly which path we need to go down. And this slide just lays it out perfectly. Two totally opposite missions. For an ischemic stroke, a clot, our one and only goal is to get that blood flowing again. But for a hemorrhagic stroke, a bleed, the goal is to stop the bleeding. You can see why giving a clot buster to a patient with a brain bleed isn't just a mistake, it's a potential disaster. There is zero room for error here. Okay, so let's zoom in on the most common scenario, the ischemic stroke. This is where we as pharmacists really open up our playbook because the primary weapon we have to fight this clot is a drug. And our go-to weapon is thrombolysis. We use the famous clot buster, IV alteplase, also known as RTPA. Its job is to go in there and just dissolve the clot, reopening that blocked artery. Simple, right? Well, not exactly. We can't just give it to everyone. And this table, this is our final safety check. As pharmacists, we are the absolute last line of defense here. Our eyes go straight to that blood pressure. Is it under 185/110? We're scanning the patient's history, any recent head trauma, major surgery. And of course, we're all over the labs. What's the INR? What's the platelet count? Any one of these can be a hard stop. And on top of all that, there's the clock. The big one. The standard accepted window to give alteplase is less than 4.5 hours from the time the patient was last seen normal. This is not a suggestion. You go past this window and the risk of causing a dangerous bleed just skyrockets. Remember, time is brain. So let's say the patient is a candidate and the infusion is running. Our job isn't done. We're on high alert for two major red flags. The first and most serious is a brain bleed. Any sudden headache, nausea, or change in their neurostatus, you stop that infusion and get a stat CT. The second is angioedema. It's rare, but it's a big deal. And here's the key pharmacy pearl. The risk is higher for patients who are already on an ACE inhibitor. Okay, what about antiplatelets, like aspirin? The timing here is absolutely crucial, and it all depends on one question. Did the patient get alteplase or not? If the answer is no, we give aspirin right away, as long as that first CT ruled out a bleed. But if they did get alteplase, you have to wait. We hold off for 24 hours and get another CT scan to make sure there's no bleeding before we even think about starting aspirin. All right, let's switch gears completely. Let's talk about that other 15%, the hemorrhagic stroke, the bleed. Here, our entire strategy gets flipped on its head. We're not busting anything. We are in full-on damage control mode. With a brain bleed, the number one priority, above all else, is to reverse any and all anticoagulation the patient is on. And we have to do it fast. Every single minute that their blood is thin, that bleed in their brain can get bigger, causing more and more permanent damage. And this table? This is our domain. This is where our specific drug knowledge isn't just helpful, it is literally life-saving. For warfarin, you're reaching for PCC and vitamin K. For dabigatran, it's idarosizumab. For the factor XA inhibitors like apixaban and rivaroxaban, it's andexanet alpha. Knowing these pairs cold, making sure they're in the Pyxis, and knowing how to dose them, that is a core pharmacist function in this emergency. Okay, let's fast forward. We've made it through the chaos of the acute phase. The patient is stable. But our job is so far from over. In fact, you could argue the most important part is just getting started, preventing another stroke and making sure the patient gets home safely. So how do we stop this from happening again? Well, our strategies are really targeted. If the stroke was caused by AFib, a DOAC is pretty much the standard of care now. If it was a smaller stroke or a TIA, we're looking at short-term dual antiplatelet therapy, usually aspirin and clopidogrel, for about a month. And of course, for any patient who can't move around much, we're always thinking about preventing blood clots in their legs. And this brings us to one of our most important jobs, discharge counseling. This is so much more than just putting meds in a bag. This is our chance to build a safety net. We need to clearly explain what each new med is for, why it's so important to take it every single day for the rest of their life, and really hammer home the side effects to watch for, especially bleeding. And we always finish by asking them to explain it back to us, just to make sure they've got it. And you know, it's so important to remember that we aren't doing any of this alone. The data is crystal clear. Patients have the best outcomes when they're cared for by a whole team working together on a dedicated stroke unit. And the pharmacist is a vital, central part of that team, from the second the patient hits the door until the day they go home. So, I'll leave you with this question to think about. After the adrenaline rush of the code stroke is gone and things have calmed down, what comes next? How will you, with your unique expertise, really optimize this patient's long-term recovery and do everything in your power to make sure this never, ever happens again? Because that, right there, is where we make our most lasting impact.